Without wasting time, let's go into the first topic of discussion today, that is sacral plexus anatomy and the posterior approaches of the sciatic nerve block. So I have no conflict of interest. The illustrations and schematics used in this presentation are my drawing, and appropriate patient consents or volunteer consent have been obtained. So I will be focusing on the sacral plexus block, various approaches, and the proximal sciatic block. The sacral plexus block or the sciatic proximal sciatic nerve block is usually indicated for unilateral surgical anesthesia or analgesia, along with the lumbar plexus, femoral, or the saphenous nerve block in knee, hip, and ankle or foot surgeries. The contraindications includes the local infections, especially the bed sores. If the patient is on anticoagulants or having coagulopathy with pre-existing central or peripheral neuropathy, patient refusals, and allergic to the local anesthetic are absolute contraindication. In case of pre-existing neuropathy, you can think about the risk-benefit ratio, discuss with the patient and attendants, and then you can go ahead with the block after proper documentation. Coming to the functional anatomy related to the sacral plexus and the sciatic nerve block. As you know, the sacral plexus is formed by the union of the lumbosacral trunk formed by L4, L5, and the first three, that is S1, S2, S3 ventral primary rami. Both anterior and the posterior division comes to form the sacral plexus. If you look at the root value of the tibial and the common peroneal component, the tibial is from the L4, L5, S1, S2, and S3, all the components, whereas the common peroneal comes from the L4, L5, S1, S2. The second important point is the posterior femoral cutaneous nerve. It comes from the S1 posterior division, anterior and posterior division of the S2, and the S3 posterior division. And the simple way to remember the root value is -1 + 1 rule. Start with the superior gluteal nerve. Take first three, that is L4, L5, S1. Now, subsequently, -1 root and +1 root. That is, for inferior gluteal, if you look at this, L5 -1, that is from L4 to L5, S1, S2, and +1, that is S3. Okay. For similarly, for posterior femoral cutaneous nerve, S1, S2, S3, and for pudendal nerve, it is S2, S3, S4. It's a simple way to remember the sacral plexus most important branches and their root values. The sacral plexus is formed within the pelvic cavity, and after formation, it comes out of the metasciatic foramen and it lies anterior part of the piriformis muscle and covered anteriorly by the pelvic fascia. Pelvic fascia actually separates it from the hypogastric vessels and the pelvic viscera. After formation, it runs below the piriformis muscle. Sometimes the common peroneal branch also can pierce the piriformis muscle instead of running below it. And then it travels between the greater trochanter and the ischial tuberosity. And then it enters into the posterior compartment of the thigh on the lateral side of the biceps femoris muscle. Then it travels up to lower third of the thigh, where it diverges into the tibial and the common peroneal. It gives numerous branches to the hip joint, knee joint, ankle joint, and also supplies the muscles. Semitendinosus, long head of biceps, adductor magnus, the ischial head, semimembranosus and semitendinosus, all these are supplied by the tibial component of the sciatic nerve, whereas the common peroneal nerve supplies the short head of biceps femoris, that is the muscles of thigh. And in the leg, posterior and the medial part are mostly supplied by tibial component, whereas the lateral part is by the common peroneal nerve. And in the foot, it is mostly by the tibial component. Whenever you are deciding a block for a particular surgery, you should consider the dermatome, osteotome, and myotome separately. If you see the dermatome, the medial side is supplied by the saphenous nerve, that is from the posterior division of the femoral nerve, from the lumbar plexus, and the rest of the area below the knee joint is supplied by the sciatic nerve, and osteotome is mostly by the sciatic nerve. And the peculiarity of the dermatomy is the posterior part of the thigh is not supplied by the sciatic nerve. It comes from the posterior femoral cutaneous nerve. That's why if any surgery involving this area, like skin grafting or application of the tourniquet in the mid thigh or upper thigh area, so in this kind of cases, you need to block, or you have to choose the block which can involve the posterior femoral cutaneous nerve also along with the sciatic nerve. The rest of the area, as I have mentioned, as like other blocks, the informed consent, IV access, monitoring, last kit, and aseptic technique to be followed. Sciatic nerve is a deeper block, especially the proximal one and the sacral plexus block, and patient needs sedation also, and also the local infiltration before inserting the nerve block needle. 50 to 150 millimeter of 22 gauge nerve block needle is usually used according to the build of the patient and the area where you are doing the sciatic nerve block. If you are using PNS, the initial current rate would be 1.2 to 1.5 milliamps. The pulse width would be 0.1 millisecond and the frequency 1 to 2 hertz. If you are using PNS along with the ultrasound, that is dual guidance, here we need to identify the nerve for not to localize. For identification, 0.5 milliamps current is enough. For ultrasound guided blocks, linear in case of pediatric and lean and thin patients, adult patients, and curvilinear probe in case of obese patient is needed. And local anesthetic, ligdocaine, bupivacaine or levobupivacaine, ropivacaine, and along with adjuvants. So here in Ganga Hospital, we use dexamethasone as adjuvants. You can use according to the availability at your setup. And the concentration again depends on the indication. If you are using this block for the analgesia purpose, then the concentration like 0.25% bupivacaine or 0.2% ropivacaine is enough. But you have to go for higher concentration if you are using for the surgical anesthesia, 0.5% ropivacaine or 0.75 ropivacaine or 0.5% bupivacaine. Coming to the responses, the twitches of the foot or toes are accepted at high sciatic nerve block or sacral plexus block. We accept the twitching of hamstring muscle also, because you are blocking the sciatic nerve before giving off the hamstring branch at higher level. But at lower level, like from after subgluteal area to the popliteal sciatic area, there we don't accept the hamstring muscle. We go for the inversion or plantar flexion and dorsiflexion. Here, one important point is the inversion response is most preferred response, and the eversion one is the least preferred response. Why so? We have to understand the inversion is caused by the tibialis anterior and the tibialis posterior muscles. Tibialis anterior is supplied by the deep peroneal nerve from the common peroneal nerve, and the tibialis posterior is supplied by the tibial nerve. So whenever you are doing at high sciatic nerve, it may not be that important. But whenever you are doing at distal level, that is the popliteal sciatic nerve, if you are getting inversion response, that means you are at the sweet spot, or your needle tip is located in between the two components, that is tibial and the common peroneal. So that is the best place to give this block. And similarly, if you see the muscles causing eversion, that is the peroneus longus and the peroneus brevis, that is supplied by the superficial peroneal nerve. So that's why eversion is the least preferred response. What if after surgery, the surgeon has put POP cast? In those cases, the eversion and inversion response is not possible. So in that case, toes flexion or toes plantar flexion or dorsiflexion is accepted as the response, depending on the level at which you are blocking. For proximal sciatic or sacral plexus block, both are, any one of these is accepted. So coming to the sacral plexus block, first I will go with the PNS guided sacral plexus block. Here we have two approaches. One is Mansour's parasacral approach, another is the modification of this approach. So in Mansour's approach, what we do is we identify the posterior superior iliac spine and the ischial tuberosity and join these two. 0.6 centimeter below the posterior superior iliac spine is the point of needle entry. And the modification was done is this line was divided into three parts, and first 1/3 and 2/3, and the junction between the two is taken as the needle entry point, this point. So recently, Dr. Diwan has published this paper, and he has concluded that in high-risk geriatric patient, around 50 patients they studied, for fracture IT patients, this lumbosacral plexus block can be used as an alternative to neuraxial block for early surgical repair. So here I'm showing the PNS guided sacral plexus block. Many people are doing it now because everyone does not have access to the ultrasound machine. So it is a very simple landmark and very simple approach if you follow the basic guidelines. So initially you saw that my extension line was open to the air. I usually keep that because there are a lot of vessels are there, pudendal vessels, inferior gluteal vessels, superior gluteal vessels. So if you connect the local anesthetic syringe and flush it with the syringe, so your backflow of the small veins may not come out. So even on aspiration, it may get collapsed and you may not detect the intravascular placement of the needle. So this practical point you need to remember. So that's why I keep it open. If it is inside the blood vessel, immediately it comes out. So once you get the desired twitches at less than 0.4, just aspirate and inject. Now, coming to the troubleshooting while doing ultrasound guided or dual guidance or PNS guided. So you can directly stimulate the gluteus maximus muscle or inferior gluteal nerve. You will get the gluteus maximus contraction. Just go ahead. There, after piercing the piriformis muscle, you might get contraction of the perianal area. Patient might complain of paresthesia or adduction, and because of obturator nerve stimulation, stimulation of the nerve to quadratus femoris or superior gluteal nerve can happen. Just redirect the needle caudally and medially. And then if it touches the bone indicates that either it is touching the greater sciatic notch or the sacrum. So if it is, your needle is not absolutely perpendicular to the skin, then you have to redirect the needle accordingly. And remember, hitting the bone also can be used as a depth test. So don't go beyond 2 centimeter once you hit the bone. Just like the lumbar plexus, whenever you hit the transverse process, you don't go beyond 1.8 to 2 centimeters. Similarly, here also, don't go beyond that because you might injure the pelvic viscera. So coming to the ultrasound guided sacral plexus block, we have 4 approaches. So first 3 are the direct sciatic nerve block, and last one is the facial plane block recently added to the literature. So you don't have to remember or practice all these things for theoretical purpose or for your exam purpose. You might need to know all these things, but I would suggest to learn and practice on one approach and follow it and become a master of it. So in Taha's approach, point is taken 8 centimeter lateral to the uppermost point of the gluteal cleft, and the medial part of the probe is placed there, and then look for the sacral plexus or the sciatic nerve. And the most important landmark here is the posterior border of the ischium. This has a typical curvature. And then if you are not getting at this point, then what you have to do, you have to go cranially to visualize the ala of the ilium. Ala of the ilium will visualize as a straight line, that is hyperechoic line casting anechoic shadow, that is the bone. And you will be able to visualize the gluteus maximus and the medius muscle. Then gradually scan caudally, so you will get a notch or a gap there, that is the greater sciatic foramen. Now once we get the gap, usually you might get the nerve. If you are not getting the little caudal tilt, that is your hand will be tilted cephalad, but your probe will see caudally. So because you need to align your probe perpendicular, that is 90 degree to the sciatic nerve or sacral plexus to visualize this. That is the basic ultrasound principle. So the probe position will be here, and here is the uppermost part of the gluteal cleft, 8 centimeter lateral, then go caudally, and then you will see a picture like this. This ischium curvature, posterior border of ischium has a typical curvature. In bendstone approach, that is popularly known as parasacral parallel shift, the midpoint of posterior superior iliac spine and the greater trochanter is taken, and the ultrasound probe is placed on the medial half of on this line. And then here you will again see the straight line, that is area of the ilium, and then scan caudally and medially. Here the scanning technique is caudal and medial. So at this point, you will, this is the first point, you will see a area of the ilium, and then when you go caudally and medially, you will get on the medial side sacrum, on the lateral side ischium, and greater sciatic foramen. Through the greater sciatic foramen, you will see the sciatic nerve, and the from the sacral plexus is coming out. Here we are visualizing the sciatic nerve longitudinally. In Taha's approach, we are seeing the cross section of the sciatic nerve. That is the difference. So here I'm performing the bendstone approach with dual guidance. Here you can see we are getting the hamstring contraction that is acceptable at this level. And here you can see the moment you inject the drug, you can see a nice spread of the drug inside the paraneural sheath, because sciatic nerve possesses the paraneural sheath from the beginning itself. And you can see the longitudinal section of the sciatic nerve coming out of the greater sciatic foramen and going over the ischium. You can see here nicely, and surrounding the nerve there is local anesthetic. Yeah, here you can see it's clear now. Another approach is the Caesar's approach. Here two important landmarks are posterior superior iliac spine and the sacral hiatus. First, you have to join these two lines, and at the midpoint of this, a perpendicular is to be drawn with a similar length of this line. So at this point will be your point for the probe placement. So probe will be placed here. Now coming to the more interesting one, that is the parasacral ischial plane block, or parasacral interfacial plane block, or PIP block. This block was described by Dr. Madan Narayan and Dr. Tulgar simultaneously with two different names. The scanning technique will be similar to bendstone technique, and here instead of blocking the sciatic nerve directly, what we are doing, we are targeting the ischium. We are hitting the ischium and depositing the drug. The drug is spreading between the epimysium of the piriformis muscle and the pelvic fascia, and the drug is spreading medially and blocking the sciatic nerve. So chance of direct nerve injury is less. And we have also started using this block for post-operative analgesia. Now, for a quick recap, ultrasound-guided sacral plexus, mostly four important variations are there. In bendstone approach, the probe is placed here, parallel to the line between GT and PSIS. In Taha's approach, we are seeing it in the cross-sectional view. In Casal's approach, we are coming from medial to lateral, and in parasacral ischial plane block, we are using same bendstone's approach. It's an approach for scanning technique. Now coming to the proximal sciatic nerve, we have Labart's Winnie's modification, Franco's approach, and the popular subgluteal GTIT or Raj technique. These are the PNS guided approach. And the transgluteal approach is out of practice because of two reasons. One is it is a deeper block. The patient will have pain, a lot of pain while you are performing the block. And the second one is with ultrasound also, the visibility is very poor. So that's why for theoretical purpose, I'm just telling you about the landmark. For Labart's approach, this was the original classical approach. The posterior superior iliac spine and the greater trochanter are the important landmark, and a perpendicular is drawn at midpoint. Perpendicular of 4 centimeter is drawn at the midpoint, and there is the your needle insertion point. And similarly, the Winnie's modification, he took another landmark, that is the sacral hiatus, and he joined the sacral hiatus with the greater trochanter. So this perpendicular usually intersect with the line between greater trochanter and the sacral hiatus, and that intersecting point is the point of needle insertion for Winnie's approach. This is the basic difference between Winnie's and it. Now coming to the subgluteal approach, subgluteal space is an anatomical space anterior to the gluteus maximus muscle and behind the quadratus femoris muscle. Medially, there is ischial tuberosity and lateral is the greater trochanter of the femur. In this space, medially, you might find origin of the biceps, short, semi-tendinosus, semi-membranosus, and it usually in ultrasound, you will find a hyperechoic oval shaped or triangular shaped structure that is the sciatic nerve in this hypoechoic area, that is the subgluteal space. The other important structures are inferior gluteal vessels, the nerve to long head of biceps femoris, posterior femoral cutaneous nerve of thigh, the vasa vasorum of the sciatic nerve, ascending branch of the medial circumflex femoral artery. All these important vascular and the neural structures are there. So theoretically, if you block the sciatic nerve here, it should also block the posterior femoral cutaneous nerve of thigh. So up to this level, that is subgluteal space from the sacral plexus, I mean Mansu's parasacral approach to this approach, you can block the posterior femoral cutaneous nerve of thigh. Later, it usually becomes superficial and supply the skin. So other approaches, it might not get blocked. So in this GTIT or approach, it can be performed either laterally prone or semi-prone and popularly known as the Raj's lithotomy approach, that is in the supine position or lithotomy position. The two landmark GT and IT are identified and they are joined, and at the midpoint, the needle is inserted. The needle is inserted at perpendicular to the skin and usually within 5 to 7 centimeter, you will get the desired evoked motor response, and decrease it up to 0.4 and deposit the drug. So it's a very simple approach. Even in obese patients also, you can easily palpate the greater trochanter and the ischial tuberosity. If in case you may not palpate these two landmarks, then you can go for the Franco's approach. That is very simple approach at the mid gluteal level. Just identify the midpoint of the mid intergluteal cleft from visual inspection, and a 0.10 centimeter lateral to it is the point of needle entry. Because here at this level, from mid gluteal to subgluteal level, the sciatic nerve travel constantly parallel to the midline. So that's why within this range, you can block sciatic nerve block with this approach anywhere, that is 10 centimeter from the midline. Coming to the ultrasound guided one, so here the probe is placed on the line between the GT and the IT, and the sciatic nerve is visualized. Either you can come from lateral to medial or out of plane technique and deposit the drug there. Because medial side inferior gluteal vessels, you might see it sometime, it might be seen. So that's why medial to lateral needling is avoided. So here you can see I'm doing an out of plane technique for subgluteal sciatic nerve block of ultrasound guided. Most of the time we found that sciatic nerve is placed more towards the ischial tuberosity rather than exactly at the midpoint. And you can see the nice local anesthetic distribution. This is the post-block picture within the epimysium of these two muscles. So the limitation of the posterior approaches are it is time consuming because and require assistance, because you need to place the patient in prone position and then need the patient in supine position for surgery, like that. So it is time consuming, and the probe stabilization, especially in lateral position, that is Sims position, is sometimes find it difficult, and image optimization also. And the most important is the in prone position, if these blocks are the deeper blocks, so you need sedation. So there is always a risk of airway compromise in prone position. And in patients with spine surgery, morbid obesity, hemodynamic instability, pregnancy, and in case of mechanical ventilation, this position change could be dangerous for the patient. So in those cases, the anterior approach is preferable, and my next speaker will discuss about it. Coming to the complications, the nerve injury can happen either from the direct needle trauma or injection of the local anesthetic with adrenaline, and infections. Proper aseptic technique can be used to avoid infection. The vascular puncture and hematoma can happen, as you can see. The proximal sciatic nerve, either at the level of sacral plexus or at subgluteal level, everywhere it is associated with a lot of blood vessels. The perforation of the pelvic organ, when you go beyond 2 centimeter, the pudendal nerve block can happen. Local anesthetic, systemic toxicity, delayed recovery if you are using adjuvant and higher concentration, and pressure sore of the heel due to insensate food, and delayed detection of the compartment syndrome. This can happen when you are using higher concentration of the local anesthetic. And pressure sore to heel, it can be avoided by placing a heel pad. This can happen with continuous sciatic nerve block. To conclude, the response less than 0.2 milliampere, you should avoid injecting the local anesthetic, and try to inject the local anesthetic below the paraneural sheath, that is the subparaneural injection, for early onset and effective blockade. And what will be the first sign of blockade? That is, a patient will be unable to wiggle their toes. So this movement will not be there. So that is the first sign of easy to check.
That's all for today. Thanks for watching. Catch you in the next video. Until then, keep blocking, keep rocking.